Hello and thank you so much for joining us today for the webinar One Size Doesn't Fit All. No one material solve all problem. We would like to thank Dr. Hassan Maghaireh for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Hassan Maghaireh.
Okay, my name is Hassan Maghaireh. I'm a dentist with a special training in dental implants, and I'm very delighted to be here with you today at the botiss webinar. And I would like to thank botiss Academy for this kind invitation. We're going to talk about guided bone regeneration in the aesthetic region in implant dentistry, and we're going to focus on the theme one size doesn't fit all. Yeah, welcome to everyone all around the globe from Manchester, where I'm based at the moment. I teach dental implants at the University of Manchester on their MSc program, and I'm very proud to be part of that team. Also the head of the scientific committee of the British Academy of Implant and Restorative Dentistry, and I'm in Leeds. And I'd invite you all to go and check the website Academy with all the events. And I'd like to thank them for the kind sponsorship. I'm also a full-time implant clinician. And this is where I'm based in Leeds, where I place and restore dental implants. So the challenge starts basically for any implant dentist whenever the tooth is out. Patient come to you with a missing tooth, and they would expect you to replace this with a dental implant. But what they don't know really, that there are some challenges we have. One of them, the biological challenges. There's a huge difference between the biology, the anatomy of a natural tooth and a dental implant. And this is something we have to take in consideration. We all know that the difference in the bone attachment, the periodontal ligaments, and the type of soft tissue we have around dental implants in comparison to a natural tooth. But then the problem we have in all our dental practices that our patients expect us to provide things to be as best as possible. They still want them to be cheap and fast. So the challenges we have in our dental private practice in implant dentistry and in every branch of dentistry, that our patients would like to have this combination. And we all know it's not really straightforward. When things are good, they can't be cheap. When things are fast, usually they're not great quality. And if they're fast and cheap, they're not going to be good quality. So this is something we have to face in our dental practice. Furthermore, our patients nowadays, in 2017, they're very well educated. And whenever they come to you ask for a dental implant, they expect things to look as natural as possible. Our patients they go on social media, they go on TV, and they're all well-oriented about aesthetics. So this is another challenge. Gone the time when it was all about placing a dental implant well integrated end off. Nowadays, the challenge is the white and the pink aesthetics. Furthermore, they have to be reliable and durable. Any product we use for our patients, whether it's a dental implant itself, or the bone graft, or the membrane, it has to be reliable and durable, giving us high safety for our patients and having great results for our patients. Everything we do in our dental practice is based about creating positive patient outcomes. And you get this by using good clinical art, using the up-to-date science, and having in your hands products which give you best practice. And this is a duty on every single implant dentist to provide their patients with the best products in the market. So definitely the decision shouldn't be what's the cheapest product in the market. It's what's the safest, the most reliable, and what can give us a durable result. Let me go through one of the cases to show you the workflow we follow in our private implant practice in Leeds. This is Alvin. Alvin came to me with a failed upper central incisor. As you could see, it was a failed post-crown. When you look carefully, you could tell that this failed post-crown basically has a cracked root and the tooth had to come out. So the tooth was extracted as gently as possible. preserving the labial bone and the surrounding soft tissue. And from there, we use Essex retainer as a temporary backup, but I like usually to use my rochettes. I always try to aim for a fixed temporary, because with fixed temporary you get the best soft tissue maturation rather than a denture whenever you can. But we know these fixed temporaries, they're cemented using adhesive cement, so they tend to come out. And that's why we like to have this Essex retainer as a backup. So we fit the temporary, and according to the Cochrane systematic reviews, we know that the safest implant practice and the one which can give you the most reliable aesthetic results is the one when you can go back and place your dental implants 6 to 8 weeks afterwards, which we call early placement in the anterior region. The advantage of that you're going to get a huge amount of keratinized mucosa. You're going to get initial remodeling in the bone, but not too much, so you're not going to lose the bone compared to delayed. And if you have any remaining bacteria, it's going to be completely gone, hopefully. So the risk of post-op retrograde peri-implantitis will be very little. So you raise the flap as you would do. You clean the socket gently, try to preserve the labial flap, and use your surgical guide to place your dental implant. You place your dental implant in the correct position. We're going to talk about this, the ideal position from a 4-dimensional implant placement to give you the best results. And then you place your dental implant. In this case, we managed to achieve 25 Newton centimeter. So obviously immediate loading wasn't an option. We all know, again from the Cochrane systematic reviews, that you should aim for 35 Newton centimeter or higher before you can go for immediate loading. So in this case, we decided to place the implant in the correct position, 3 mm away from the future cement enamel junction, 2 mm lingual to the future labial profile of our future tooth. And because we managed to get 25 Newton centimeter, we're going to go for delayed loading. So I tend to place dental implant in the correct position. And before moving to the guided bone regeneration, we have to look at the soft tissue. The soft tissue will include some soft tissue management, which in this case, we looked at the labial frenum. It's very prominent. So sometimes you can go for labial frenectomy to help to avoid any sort of post-op pressure and recession on the flap. From there, I place my healing abutment. And please look at the healing abutment here. It is recommended to go for a narrow healing abutment at the initial stages of your implant placement. And I'd like to have my healing abutment just flush or about just above my the soft tissue level. We don't want to be much higher to encourage more gum to grow around my healing abutment. Now we're going to go for the guided bone regeneration in this case. But first we have to clean the bone. We go for decortectomy to get some blood to help with the blood supply. And then I reach for my membrane. In this case, we use Jason membrane from botiss. And I use the little white paper in the sterile pack, use it as a template. So you start cutting and manipulating till you reach a point that, yeah, this is the shape you like. And then you use that against the membrane you're going to use, and you cut your template in a clean, easy, straightforward way. Once the membrane is ready, you adapt the membrane on the top, and you lift the membrane back and use your cerabone. In this case, I decided to use cerabone, which is a Xenograft from botiss, because all what I wanted here to get the nice convexity, which we're going to make the soft tissue look good and give us this natural feeling we would like around our dental implants. So this is my cerabone, and what I like about cerabone that it's hydrophilic, which makes it very easy from a handling point of view. You can see they grab together. They don't just go everywhere. So from a manipulation point of view, that's very easy. But what I didn't show you earlier on, that we had exposed 3 mm exposed threads around our dental implant. So basically, I used some autogenous bone. I scraped it from all around and covered the exposed threads according to the ITI guidelines. And on the top of that, we put the cerabone to give us the convexity we want around our dental implant. We try to give it the sausage shape to give us the convexity we like. And I like to aim actually for up to 4 mm thickness. If you can get that 4 mm, great. But if not, at least this 4 millimeter, if it resorbs, we will still get the minimum 2 millimeter around our dental implant to get the long-term stability. So everything's sorted. The good thing about Jason, it's once it's wet, it settles nicely. And again, it's very easy to use. We close nicely and make sure that we don't do labial flap advancement because we don't want to move the keratinized mucosa. We just put everything back where it was very gently. And we send the patient home with my fixed temporary rachette. And I like to keep it, I like to play it safe. So I like to keep it in the upper jaw in my private practice 12 weeks before we move to the second stage. I know some people go earlier, but this is what I like to do in my private practice. After 12 weeks, you remove the healing abutment. And as you could see, because we use a narrow healing abutment, we've got a huge amount of keratinized mucosa. And now it's time to move on to the prosthetic soft tissue management. And you could do this by building a temporary crown. Now, you could either go for a chairside temporary crown, or in some challenging cases like this one, we decided to go for a lab-made temporary crown. So we took an impression, we took the shade, and we managed to get a temporary crown made in the lab. The idea, as we will talk about this later on, with the temporary crown to be soft tissue friendly. And towards the end of this presentation, we're going to talk about the ideal characteristics of a temporary crown in dental implants. You put the temporary crown in, and then you check the bite, make sure everything is okay. And you call the patient every 3 weeks, you unscrew your temporary crown and add some more to it. And the idea is to change the emergence profile from a little circle to your ideal emergence profile of your future tooth. But you don't just go push it in one go. You do it gradually. Because if you do it in one go, you might put some more pressure on the soft tissue and you get more recession than what you want. So the way of doing it to get really predictable results is every 2 weeks, every 3 weeks, you call the patient back and add 1 to 2 millimeter. You get away with that. So in this case, after 8 weeks, just to show you, we started to get some sort of emergence profile, but I wasn't very satisfied yet. So the fact that I had a good temporary crown, patient didn't mind to wait. So from there, we gave it more time and we start to add more and more to our temporary crown till about week number 14. We managed to achieve a very good satisfactory emergence profile. From there, we're ready, implant integrated, soft tissue profile looking good enough. We move to our final impression. But in this case, I would like to customize my impression post because not only I would like to show the lab technician where's the implant, but I'd like also to give them ideas about our subgingival profile and the emergence. And you do this by getting a good customized impression post. And then in this case, with the help of CDT Lab in Leeds, we managed to get a screw retained crown, which looks as natural as possible. And we fit the screw retained implant crown. What I'd like you to look at that we managed, using the right technique of guided bone regeneration and the right products, we managed to preserve the labial convexity and achieve a natural looking labial profile. And this will be one of the major factors of making your future aesthetic implant tooth looks as natural as possible. So yes, the treatment took us 34 weeks in this case, but this is something where you do it in a staged approach, play it safe. And by doing this, you get predictable results. But we did say it's not only about the initial results, it's about being durable on the long term. And this is what we did. About 2 years afterwards, we took a cone beam CT scan to check all that guided bone regeneration we built. And you could see we've got 2.3 millimeter labial thickness. And this is our cerabone, which started to slowly remodel into nice natural bone, more importantly, preserving the labial convexity. So yes, it's good case, and this is what we do day by day. But what's more importantly is to have a system, to have a consistency, to be able to get good, stable results. And this is what we're going to talk about in the next maybe half an hour or so. In this presentation, I'm going to divide this presentation into 2 halves. It's guided bone regeneration for the aesthetic region. So we're going to talk about aesthetic implant dentistry and the system and the way to achieve reliable, consistent, durable aesthetic results. And we're going to talk about guarded bone regeneration, options, techniques, and materials. So let's start with the first part of this presentation, aesthetic implant dentistry. Obviously, we just said in 2017, the challenge has moved from the titanium to the pink integration of the dental implant system. At the time of Brennemark, it was all about, is it going to integrate? Nowadays, we want it to integrate in the correct position, giving us a good biological results, giving us good soft tissue integration to make the tooth look as natural as possible. Because our patients nowadays, they don't care which dental implant system you use, as long as you use it right, use good products, and then achieve a tooth which looks as natural as possible. As Belzer said in one of his articles and reports, the moment you get failure in your pink soft tissue results, whatever you do, even if you use the most expensive abutment, the most expensive crowns, you're not going to have good results. So it's not sufficient to just put a prosthetic device to underlying fixture. You need to focus on getting good, satisfactory pink results, and then the white challenge will be easier to achieve. And this is another case, another central incisor case, where we follow the system, which I'm going to show you and share with you shortly, and we managed to get good, satisfactory results. And this is what we did in this case. Implant was removed, early implant placement, and this is the final result. More importantly, this is her 7-year follow-up. Because we use the right choice of products, the right technique, we've got good stability. And you could imagine if we had some extra recession in this case with high smile line, how would have this case been really badly influencing the patient standard of life. So that's the dental implant, and you could see even the lateral profile. This is what we was talking about, the convexity, getting the convexity right. And then I would highly recommend you guys to use your pink aesthetic score to assess your case and audit your work. Am I in the right track? Am I doing good things or not? And the way to do it, that there are 7 points you check: medial papilla, distal papilla, soft tissue level, soft tissue contour, alveolar contour, color, and texture. You do that and you score for each of these 7 points: 2 if it's satisfactory, 0 if it's unsatisfactory, and 1 if it's like minor discrepancy. In this case, I audited my work 7 years onward, and I could see the distal papilla could have been a bit better, so I scored 1 out of 2. The soft tissue contour, if you compare the zenith with the adjacent tooth, I think it could have been improved. And the texture, you could see the little scarring still there. It's a thick gingival biotype, the scarring showing. So I scored 11 out of 40. The good news that usually patients are happy and satisfactory with anything scoring 10 out of 14, while dentists usually go for 11. So our patients tend to accept cases better than colleagues. But we need to focus on the fact that this 95% success rate is not really a success rate. It's a survival rate. And when it comes to aesthetics, we know, and I'm sure you share this view, that we barely get 60% aesthetic success rate. And that's because I believe some of my implant dentists or some of my colleagues in the world of implant dentistry, either they don't follow the right technique or they decide to go for the wrong products. And this is something I would like to share with you today. So let's talk about the technique. How do we achieve predictable, reliable, consistent aesthetic results? How do we get optimal results? And this is a really good reference I would encourage you all to go and check, by Boozer et al., Jomi 2004. Basically, there are 4 main points. Number 1, implant has to be placed in the correct position. You need to have good bone quality and quantity. You need to have good and sufficient soft tissue quality and quantity. And then you need to have good prosthetic design, including the provisional restoration and the final restoration. In today's presentation, I'm going to focus on the first point, correct implant positioning, and the guarded bone regeneration factors. But it's worth mentioning this recent study. It's a retrospective study where they looked at cases where they developed peri-implantitis, and they wanted to analyze the reasons behind developing peri-implantitis. And it's interesting to find that 40% of the cases were to do with wrong implant positioning. So this is something we have to look at, and we have to focus whenever we come to plan and place our dental implants. Because placing the dental implant in the wrong angulation or the wrong position can give you such failures. They might not show in the first year, but definitely, placing the implant in the wrong position will cause bone remodeling of that labial plate, and within a year or two, you're going to get some disastrous results. And the treatment of these cases is going to be really challenging. This is another case. The dental implant was placed immediately, and it wasn't really giving good results. Obviously, you could tell that the positioning of the implant wasn't right. And the moment you remove the crown, you could start to appreciate that everything was done not according to the system we were taught to do. Implant was placed too deep, implant was placed too labial, implant was placed on the wrong angulation. And as you could see here, within a year of implant placement, that very thin labial plate remodeled, and we've got recession, and here we go. Things started to look not in the right way. We went through different treatment options with this lady, and we decided that we will have to remove this dental implant and give this lady a fresh start. And this is what we did. We used this reverse torque kits, and we went for about 350 Newton centimeter in reverse, and we managed to get the implant completely out. And obviously, in my view, this is the only correct way of managing this case. So we all know from our ITI guidelines and from our basic implant research that when it comes to mesiodistal, we need to have a minimum of 1.5 millimeter space between an implant and adjacent tooth. And the idea is of that space, if that space is less than 1.5 millimeter, you're going to have very little blood supply and you're going to get bone loss. And then you're going to lose your papilla, lose your soft tissue attachments. Now, when it's come to coronoapically, we know the biological width in implant dentistry is about 3 to 4 millimeters, depending on so many other factors. That's why your dental implant needs to be placed 3 millimeter on average from the gingival line or the gingival margin of your future implant crown. And as we mentioned earlier, buccopalatally, your dental implant has to be around 2 millimeter away from the future labial line of your future implant tooth. But this is something I think I would love to know. I would love to say 90% of implant dentists follow. And we know this from our basic training. And we all know that you don't need to go for expensive, high-tech surgical guides. In this case, we kept it simple. So surgical guide in this case was just a suck down stent of the wax up on the model. And it shows me where's my future gingival line. It shows me where the implant needs to stop in relation to the future gingival line. It shows me the mesiodistal ideal position for these dental implants, and it shows me the buccolingual positioning. So using a very straightforward, cheap surgical guide, I like to think that we managed to place these implants in the correct position. Sometimes you could decide to go for high tech, and you do like cone beam CT scan, and you get your DICOM file. You either take intraoral impression, you get STL file, or you ask your lab basically to scan the model, and then you merge them together. And then from there, you have digital wax up if you like, and then using your STL and DICOM results or data, you decide the future position of the future crown, and from there the future position of your dental implant, and from there you develop a surgical guide which will guide you to place the dental implant in a restoratively driven method. Now, where people sometimes go wrong is this, the fourth dimension. Let's go through this. We all know, and let's agree on this fact, that placing the implant in the wrong or right position can make or break your peri-implant bony and soft tissue level. And this is what I'm going to talk about in the next 5 minutes. I think I've been in this career for a while, and I could tell nowadays there are two different types of implant dentists. Some dentists they just focus on the primary stability. They just want to place implants in bone to get really high stability so they can sleep well that night. Another dentist, they say, right, I've got this implant, I can place this implant, but the challenge is going to be in the second stage when I come to restore this dental implant. So they focus on placing the implant within the prosthetic envelope. So let's show you the difference. First of all, this is a sagittal section of an interior tooth, just showing us the tooth, showing us the labial plate, and I'd like you to appreciate the fact that the labial plate is very thin. And from that image, you could see the biological width as well. And let's agree that this is going to be our prosthetic envelope. This is ideally going to be where the future tooth, the future crown going to be on top of my dental implant. People who focus on the primary stability will look at the scan and say, wow, look at that palatal bone. This is amazing bone. We've got loads of bone, and let's place this dental implant in that bone to give us a stable, safe dental implant. And then we can sleep well that night. Or other people will say, well, actually, it's about this. It's about the implant being placed outside the prosthetic envelope. We don't want that. We want to focus on the fact that this is our main concern, my future prosthetic envelope. And we know that the implant is the extension of my future tooth. And I place the dental implant in the correct position, even if that means I'm going to perforate apically, because what really matters is the head of the implant is going to be within the prosthetic envelope. And that means it's going to be straightforward implant restoration. The other thing is, with the way, when you start placing implants in the wrong angulation, in the wrong fourth dimension, most likely the coronal part of your dental implant is going to be very close to the labial plate. And we know labial plates are made of cortical bone. We know the moment you start compressing cortical bone, it will disappear. While here, when you place the implant in the correct prosthetic orientation, you're going to be away from that labial plate. You're going to either graft it in case of immediate or early placement, or in case of delayed placement, you're going to have some space where you can build your guided bone regeneration and still stay within the bony envelope. And that's what makes big difference. So I'd like you to agree with me that this is not the ideal implant orientation. And in ideal world, this is what we need to do. Change the angle a tiny bit to stay within the prosthetic envelope. Here we go, we are within the prosthetic envelope. Now, if you're worried about perforation, I'm sure there are so many dental implant systems in the market where they taper, and that can help you to avoid apical perforation. In this case, a Straumann bone level taper can do the trick, as I do in my dental office. So this implant is within the prosthetic envelope, and it's going to be easy to restore. But let's appreciate the fact that, like it or not, this is going to be only restored using a cement retained crown. And we know the limitations of cement retained crowns nowadays. We know that a huge amount of peri-implantitis can be due to excess cement. And we know that the hardest cement to clean is the buccal cement. You could easily floss mesiodistally and remove that. Now, even if you use periapical X-ray and radiopaque cement, if you do have excess cement mesiodistally, you could find it on the X-ray and easily go back and remove that excess cement. The issue here, if you have buccal excess cement or lingual, you're not going to see this on the X-ray, and this can cause further damage in the future. Not to mention the importance of having retrievable dental implant crowns and restorations. Things can go wrong in the future. We should always have plan B. We should always plan for failure. So if you have a cement retained crown and you use a strong cement, you're not going to be able to retrieve it. If you use temporary cement, you're going to have so many episodes of crowns coming out. And the problem is patients will call and say, my implant came out. They won't say my implant crown came out. So by the time they reach your office and you explain to them it's a crown, they would have told the neighbors, the family, the husband, the wife, everyone that the implant placed by Hassan is out. And this is not a very good publicity. Food for thoughts for you. Anyway, so the best way of doing it is to angle the implant furthermore and be within the prosthetic envelope, but more importantly, in the anterior region, try to aim to have the implant crown, the head of your implant, coming at the cingulum palatal region. By doing this, you can definitely go for a screw retained crown, and more importantly, actually, you're going to have a bigger labial gap, which means bigger chance of more guarded bone regeneration, more soft tissue stability. And obviously, that importance becomes even at higher significance when it's to do with bridges. You can easily retrieve the bridge or the crowns easily. Right, so when it comes to guarded bone regeneration, I'd like to think that it's to do with the prosthetic envelope. When it comes to do with the biological implication, you need to get the prosthetic envelope right. You need to get the emergence profile of your implant right, and you need to get the implant placed in the right position. And this all starts at the first session, the treatment planning session. You plan the implant to be placed in the correct position, and accordingly, you do your surgical guide, and accordingly, you place your dental implant. Everything else will just fly smoothly, and you're going to restore this dental implant in a correct position, in a correct, easy way, and you're going to give some stability. But also, as we said, by placing the implant in the correct position, will create you space where you can do some sort of guarded bone regeneration. I personally like to fill this jumping gap with either autogenous bone or allograft. And I'll talk to you shortly why allograft, why autogenous, why not xenograft. And then on the top, obviously, where we want to build the convexity, I would like to go for a slowly resorbing bone material. And this is going to be my xenograft. In this case, I'd like to go for cerabone. And then I build my membrane on the top. And I usually like to place my dental implant and put a short healing abutment, even in submerged protocols, because this short healing abutment can support my membrane. So my membrane is going to be at a higher level in comparison to the shoulder of my dental implant. And by doing this, I'm going to create a dead space area where I can fill it with some more bone. So I'm grafting even at a higher level of my dental implant, which will give me better soft tissue stability. And as I told you earlier, I'd like to aim for a minimum of 2, ideally around 4 millimeter labial grafting to give me long-term stability. And this is what we're talking about. You know, when you post-op, I still have my desired labial bone, guarded bone regeneration, giving me the stability I want. Placing the implant in the wrong position will make it hard for the bone to stay, will make it hard for the guarded bone regeneration to work and give you correct results. As in this case, you could compare the results here with another case where implant was placed in the right position, guarded bone regeneration was done easily, and no pressure within the prosthetic envelope for the implant, within the bony envelope for the guarded bone regeneration, and we've got good, predictable, reliable long-term results. So to summarize, you place the dental implant as an extension of your prosthetic envelope. If you're serious about your aesthetic implant dentistry, this is something you need to have as your primary priority. Place your dental implant within the prosthetic envelope of your future tooth. Make sure that you get the correct emergence profile, right? Placing the implant to lingual will give you ridge lap emergence profile. Placing the implant to labial will give you too convex labial profile. Both these will give you bad biological integration. And then, this is what I do. I'm not too scared if I have perforations. This is why we have GBR, to deal with these perforations. The main priority, place the implant in the correct position. And then I would like to use the correct type of bone grafting for the correct defect, for the right defect. I don't have one product to answer all questions or deal with all problems. I'd like to have autogenous bone to covering my exposed threads, or if I don't have autogenous bone, then I will use my allograft. In this case, I'd like to use maxgraft from botiss, because this, as we will see later on, will be the closest bone grafting material to autogenous bone from a biological integration point of view. But on the top, to preserve the convexity and give me good long-term aesthetic results, I would like to use a slowly remodeling bone graft material. And in this case, I've used cerabone, which is a Xenograft. And then obviously, I would like to use a membrane. And we all know the many advantages of using a membrane. In this case, we use a Jason membrane, which is a slowly resorbing membrane. It's naturally cross-linked. So unlike the other cross-linked membranes, which are chemically cross-linked and they produce harmful byproducts, this one is a naturally cross-linked, so they stay longer, but when it resorbs, it doesn't cause massive inflammatory reaction. And by doing this, everything will stay healthy, everything will stay stable. So maxgraft, allograft, within covering the exposed threads, Xenograft on the top, and then, as I told you, membrane at a higher level than the dental implant to level of the healing abutment, creating a dead space area, fill it with some bone, and then achieve the stability we want. And here we go. This is another case where I decided to do cone beam CT scan at the temporary stage, 6 months after implant placement. I've got my 2.5 millimeter. I know I'm going to get good results. And here we go. This is the final case. We've got really good, stable, soft tissue profile. This is what really matters. Trying to give our patients dental implant restorations with successful pink aesthetics, successful and long-term, reliable, durable soft tissue results. And in this case, we're using the right GBR technique with the right GBR material to give us this long-term results. Let's look at this case. This is another case. Tim came to me with a missing lateral. And he also wanted to have some other veneers. So this is the wax up. I work with my colleague in my practice who does a veneer, and I do the implant restoration. We did the cone beam CT scan. And as you could see from the cone beam CT scan, there is a labial undercut. We've got a nice wide ridge, but just above that ridge, we've got labial undercut. And you could see this clinically. So the dental implant was placed in the correct orientation. This, me 10 years ago, without the proper knowledge I have now, would have been easier for me to angulate the dental implant tiny bit so the apex of the dental implant go on the palate. So then I'll get really high primary stability. But nowadays I know that this was the wrong way of doing it. I'm placing my dental implant within the prosthetic envelope within the correct 4-dimensional orientation. So here we go. This is the labial undercut. My dental implant will be placed according to my future emergence profile, like this. All right, the dental implant is going to be exposed. Maybe 2/3 of my labial of the labial profile of my dental implant threads will be exposed. That doesn't worry me. I'm not going to panic because I know I'm going to get initial stability even of 20 Newton centimeters. So what? You know, okay, implant is not really high stability, no immediate loading, and go for a submerged profile. And here we go. You can see how I'm using short healing abutments rather than cover screws, and then building the GBR using, in this case, Jason membrane, using maxgraft on the top of the exposed threads, using cerabone, and obviously we would like everything to be stable, so using the botiss titanium pins to support the membrane and give me the convexity I want. This is the way forward to get a reliable and predictable guided bone regeneration. Right, I've got 20 Newton centimeter. All right, submerge the case. Straightforward. Suture everything nicely. Day 1, day 7. Week 8, in this case, we left it 12 weeks before we made the temporary crown to start working on my emergence profile. And week number 18, we took the final impression for the final tooth. And because the implant was placed in the correct orientation, it was dead easy to create a screw retain crown on the upper left lateral incisor. And patient went to his dentist to have the veneers, everything matching. What really matters is that I know based on the biological studies done by Spray et al. And the other groups, that I have the minimum 1.5 millimeter, and I'm going to have good long-term stability. This is where we started. And just to remind you, this is the undercut we had with using the correct sequence, the correct guided bone regeneration materials, the correct techniques. We've got good long-term results. And this is what really matters. Jason, in this case, maxgraft and cerabone, and all that brought to you by botiss. We've got the stability, which will give me good long-term results. So to summarize the first part of this presentation, when it comes to aesthetic implant dentistry in general, if you're serious about aesthetic implant dentistry, there are certain facts, certain rules I would like to recommend. Number one, you need to remember that when it comes to guided bone regeneration and when it comes to aesthetic implant dentistry, we're dealing with a very thin labial plate. And we all know that labial plate can actually control the fate of your case. And we know 87% of cases in the anterior region will have a labial plate less than 1 millimeter. So, by default, 87% of anterior cases will need guided bone regeneration. I cannot remember the last time I placed an anterior case without needing to do guided bone regeneration. Not to protect the implant. No, implant will have good primary stability from going in the original bone. The guided bone regeneration in this case was there to build the convexity, give me the good pink aesthetics, and in cases of early and immediate to compensate for any future labial bone removal. Fact number two, soft tissue and soft and hard tissue defects will mostly occur whenever you place your implant in the correct four-dimensional placement. So whenever you place anterior dental implant with following the reverse treatment planning, following the prosthetic envelope, most likely you're going to end with defects. And therefore, you will need guided bone regeneration. So if you're serious about your aesthetic implant dentistry, you need to focus on having good guided bone regeneration products and techniques to give you good results. As I mentioned earlier, Spray et al. And his group, as early as 17 years ago, they established that you need a minimum of 1.5 millimeter of labial bone thickness around your dental implant to give you long-term stability. Otherwise, if you start placing the implants in the wrong orientation, making the bone very thin labially, you're going to get short-term and long-term bone loss and gum recession, which can be very embarrassing in the anterior region. So, as I mentioned earlier, to get really good pink results, to get high satisfactory pink aesthetic score, you need to master guided bone regeneration techniques. And the final thing, we talked about spray, and Grunder actually went up to 2 millimeter to get long-term stability. And then you also need a thick soft tissue around your dental implant to get stable soft tissue. And it is good to have keratinized attached gingiva to make things look nice, to make things look aesthetic, and to help patients to clean better around their dental implants. This is a case just to show you the importance of keratinized mucosa. A case I placed maybe 7-8 years ago, 2 anterior implants for an overdenture. Whenever we have keratinized mucosa, usually patients come back with very clean implants. Whenever we don't have keratinized mucosa, usually patients come back with some plaque. Because the problem they have, they're going to put a toothbrush there, no attached gingiva, no keratinized mucosa. They're going to find it very painful. So rather than brushing their implants for the good 2 minutes, they're going to do it for 10 seconds. It'll be very painful, they stop. And hence, you get plaque, and hence you get gingival inflammation, and you can get labial bone loss. You could tell the difference between the right and the left. So, back to the basics. If you want to get good aesthetic results, good biological integration, you need to aim for good bone quality and quantity, good soft tissue quality and quantity. Only then you can get some good aesthetic results. You get some good stability, you get some long-term durability, and you get nice aesthetics. But we also mentioned the importance of the prosthetic soft tissue sculpture and maturation, which is something you can do ideally at the temporization stage. I wouldn't wait till the final stage. Now, this is something you should work on in the provisional crown stage. And this is what I meant by prosthetic soft tissue sculpture and maturation. Straightforward, easy. What you need to do whenever you design your temporary crown in the anterior region to work on your emergence profile, work on the maturation of your peri-implant soft tissue, one little trick. Make sure everything supragingival has to have a convex positive profile. By doing this, you're going to deflect all the food away from the soft tissue margins. And everything subgingival has to be negative profiled, concave. By doing this, you're going to get this dead space area. This dead space area will eventually get you thicker soft tissue, but also you're not going to put any pressure on this thin soft tissue, so you're not going to initiate iatrogenic recession. I see some cases where implant dentists place the implant in the correct position, done guided bone regeneration, done really good soft tissue maturation, soft tissue management, and then they put their temporary. And the temporary, sometimes they do it in a way where it's convex all the way to the shoulder of their dental implant. And by doing this, within 24 hours, they're going to initiate some recession caused by the dentist. So definitely, this is something we need to focus on. Right, this was a brief summary around aesthetic dental implants. Now, in the next 15 minutes, we're going to talk about guided bone regeneration, materials and option. Right, let's focus that. We all agree that one size doesn't fit all. Okay, you cannot have one material answering all your challenges in implant dentistry. And to be honest, this is what I like botiss. It's like one-stop shop. You have all the different materials suitable for different challenges you can face in the dental practice. You have different types of membranes, different types of blocks, different types of particles. Even, I'm so passionate about this maxgraft bone builder, which makes your life much easier, and obviously the bone ring techniques. For today, in this presentation, I'm going to share with you my experience in allograft versus xenograft. These are the two products I use extensively in my aesthetic cases in the practice. So allograft in this case, maxgraft, this is what I use from botiss, and xenograft is the cerabone, which also from botiss. So let's remember the defect starts when the tooth is out, you place a dental implant, and to get good GBR results, you need to remember that the defect you have has to be either 3-wall defect or 2-wall defect. You will not get successful, predictable GBR with 1-wall defects or no wall defects. This is a different story. You need to be using block grafting. For GBR, it has to have a 3-wall defect or 2-wall defect. Otherwise, it's not going to work. So in the next 10-15 minutes, we're going to try to focus on different types of bone materials. We're going to talk about the different defects, and we're going to talk about the right sequence and the right GBR material. But let's all agree that whenever we want to invest in GBR, ideally we want to create bond there to give us support for the soft tissue and protect the implant in some cases. You would like to achieve mechanical stability when you do your GBR. This is a mandatory to get successful GBR. You'd like to make sure there is going to be a good source of blood supply for your GBR. You need to get a way to get proliferation of the correct cells. Let's remember, fibroblasts are really active cells. Osteoblasts are really lazy cells. So we need to block the fibroblasts, activate the osteoblasts. And it's nice to have some products which can be osteoconductive. So we all know from our biology studies that till this moment, autograft, autogenous bone is still considered the gold standard. This is when you take bone from the patient's own body. Okay, obviously the rate of rejection is going to be very little. The rate of remodeling going to be very, very quick. Every other single bone graft material is going to be not osteoinductive or osteogenic like autograft. So autograft is osteoinductive, osteogenic, and osteoconductive. Other bone grafting material are going to be osteoconductive. And this is something we all know. But we also know that this gold standard, the autogenous graft, has its own limitations. It can prolong the surgery, can cause pain if you're going to harvest it from somewhere else. It has its morbidity and mortality associated with it. And a few years ago, we used to say, well, you have to autograft because there wasn't a good replacement. But nowadays, we do have some very good, reliable, tested products. And this is what I use in my private practice. Actually, I do give my patients both options and say you could go for autograft. The advantages are XYZ. The limitations are XYZ. Or we could use something off the shelf, and I offer them allograft, xenograft, or alloplastic material. Very rare, but this is my personal view. So let's compare the difference between alloplast, allograft, and xenograft from a biological integration point of view. Alloplasts tend to remodel quickly. That's a good advantage. But it tends to resorb quickly. And this is a limitation we have to take in consideration. Allograft, the remodeling is very good, very close to the autogenous bone. And actually, yes, it does resorb, but not that much. So it gives you some sort of medium stability. That's why I would use allograft in ridge preservation techniques. I would use allograft to cover exposed threads, but I will not use allograft to build my convexity. Because if I do that, within a year, that convexity will go flatter. But what happens if I need a convexity? I will go to xenograft. Because yes, xenografts have a slow remodeling process. And most likely within 6 months or a year, if I take a biopsy, I will still find xenograft bone particles within the bone. But what's really good about it, it has a very low resorption. So it's going to give me good stability on the long term. And that convexity which I built for the aesthetic cases is going to stay there. So cerabone is my choice. And I told you I like cerabone because it's a xenograft, tested, been on the market for a long time. And I find it very easy to use cerabone. It's hydrophilic. So, I'm not going to talk about the massive biological importance of being hydrophilic, but just if you look at this photo, it shows you the spatula is nearly 90 degrees and the bone is still there. So you could imagine how easy is it to manipulate cerabone when you come to do your guided bone regeneration. This bone is taken from cows, centered to really high temperature, 1200 degree, giving you slow resorption. And that's what I mean by being hydrophilic. You could even build the convexity, go to the shelf, to the bench, get your membrane, and the convexity is still there. Other products, the moment you blood touch the product, it just goes everywhere. And then, everything goes for a waste. So this is the histology in a year's time. You're going to find some bony particles still there. Let me show you this case. This is a case, Tom had a failing resorbed milk baby tooth, deciduous lateral incisor, had to come out, and in this case, we went through different treatment options. We decided to go for immediate placement. So this is what we did, and in fact, not only we went for immediate placement, well, we managed to get high torque. So we decided to go for immediate loading, and I built my temporary crown chair site. And as we all agreed, subgingival concavity, supragingival convexity. Now you could see here that we did not have any perforation. But you need to remember, should I do nothing in this case, that bone is going to remodel and disappear. That's why we had to go for xenograft, in this case cerabone, to build this convexity. And this is at closure. We close everything. I wanted to show you that you can do GBR with immediate loading, providing you do good soft tissue management. It's all about the soft tissue management, and you get some good reliable products, reliable results. 1 week post-op, 6 weeks post-op, 12 weeks post-op, we've got the convexity we want. We've got the emergence profile, which was created through the immediately loaded temporary crown. And from there, we were ready to customize my impression pickup to follow the sub-emergence profile of my temporary crown. And here we go. I'm fitting my customized impression post. Right, okay, the other lateral was pick shape, so we agreed to go for a prepless veneer, and that's the final impression. We went for a CAD/CAM abutment for the implant at the lateral incisor, and from there we went for a cemented option in this case. We had to go cemented option, but using CAD/CAM, and that's the final restoration for the upper right veneer, final restoration for the upper left dental implant, and here we go. We've got good, stable results, and this is him 1 year post-op. We've got the minimum 2mm labial bone thickness to make sure that this bone's going to stay there, the soft tissue going to stay there, the convexity and the emergence profile of my future tooth going to stay there, and this is by using the good product for that challenge. Now, maxgraft, I told you, maxgraft is an allograft which is taken from human donors. But the good thing about maxgraft, when you get a cancellous bone, you take it from live donors. So the beauty of that, you could trace the bone to the donor, and most likely, or not most likely, they do check these patients and they screen them and make sure that everything is clean. So it's a bone you can trust. I used to use different bone from America, which allograft bone from America, which was coming from dead people, and you did not really know the history of the donor. Well, here everything is clear, and till this moment we did not have a single report of infection. The bone comes from Austria, from CTBA Bank, and it's very reliable and predictable, been in the market since 2004. So in this case, this is a lady undergoing her ortho treatment, but the lateral incisor started to develop external resorption for one reason or another. So a decision was made by the orthodontist, this tooth needs to come out. She came to see me. She wants to have a dental implant, but at least 1 year afterwards. So rather than just doing delayed placement, we said, right, we'll take the tooth out. I'm going to build the soft tissue. In this case, we use mucoderm from botiss, and then packed the socket gently using allograft, because I know this allograft going to convert into a good quality bone, which I'm going to find very useful when I come to place my dental implant at a later stage. Now, some cases you have to go for a combination. I told you again, one size doesn't fit all. So some cases you're going to do some sort of combination. And if you check the ITI guidelines, that's what they say. Try to cover the exposed implant surface with autogenous. If you cannot achieve autogenous, I tend to go for allograft, and that will enhance new bone formation. And then I'd like to go for hydroxyapatite-based filler on the facial aspect to give me the stability, which is slow resorption, maintain the facial contour. And this is what I use, cerabone. And then I get my Jason membrane, which I like to use because it's going to resorb slowly, preserve the contour I want underneath, but resorb without causing any chemical byproducts. This is a case where we had to use a combination. Dental implant was placed in the correct position, maxgraft packed on the surface of my exposed threads, and then I got my cerabone to build my convexity. And in this case, actually, I decided to use a mucoderm as a membrane as well as soft tissue grafting. So 2 in 1, if you like. I tacked the mucoderm on both sides, and this is really good advantage. And then I even sutured the mucoderm coronally to give me really good stability. You could see how we managed to build the convexity, straightforward one. So when we talk about types of defects, we know the difference between fenestration and dehiscence. Dehiscence, when you have something like in the middle, at the coronal part, while fenestration is something at the middle or the apical part. This is the difference, and we need to focus on the fact that sometimes you will not have exposed threads, but because we have less than 1.5 millimeter, you still need to go for guarded bone regeneration. So whether you have a dehiscence or fenestration or labial plate less than 1.5 millimeter, definitely guarded bone regeneration will be needed in the anterior region. In this case, okay, it's a premolar. We have 2.5 millimeter thickness. Definitely GBR is not needed in this case. In another case, you could see the whole thing exposed. Maxgraft, Xenograft, and then get this, the convexity you want. And from there, you build, you sort of do your GPR successfully. You wait, you do your temporary crown at the second stage, you do your final crown at the final stage, and you could appreciate you have managed to get good pink aesthetic score around this dental implant, and then it was easy to achieve white aesthetic results. We're nearly there. I know we've exceeded our 1 hour slot, but I think we're gonna finish very soon. When does GPR work well and when it doesn't? Obviously, it is very important to follow certain principles. A friend of mine, Marcus Schlee, recommended these certain points. The graft has to be stable. It has to be immobile. You need to have good blood supply. You need to make sure all these unintentional cells are excluded, fibroblast, and everything like this. And this follows our GTR principles. Whenever you have a space secluded, this defect secluded with a nice membrane, stop the fibroblast coming in, you're going to have good bone regeneration. And obviously, we have to add no contamination and saliva. In fact, GPR principles were recommended really as early as in the last century. But Wang et al. In 2006, he suggested the past principle. Primary closure, that's important. You need to make sure there's going to be ability to do some new blood supply and angiogenesis, space creation to maintain and facilitate bone engraft, and stability of the wound to induce blood clot formation to allow uneventful GPR. My personal 10 practical tips for you guys to get successful GPR in your clinical practice. Make sure that you create an adequate recipient site. Okay, make sure there is no periosteum on the recipient site, and the defect is either 3-wall or 2-wall defect. Okay, always place implant graft material directly against the bone and avoid any micro movement and remove any granulation tissue. Make sure there is no acute infection, because obviously this is something you don't want. And I tend to give antibiotics whenever I do GPR. This is my preference. There are some there's good evidence from Cochrane suggesting pre-op antibiotics in implant dentistry does help in reducing implant failure. We still are debating post-op in implant dentistry, post-op antibiotics. But my personal preference in my private practice, whenever I do GBR, I'd like to give post-op antibiotics. And we said the more walls remaining, the more predictable results. Obviously, flap margins try to be away from the membrane, and when you put the flap back, it needs to be not on a membrane. You need to have really good soft tissue management to avoid saliva contamination during and after. You need to provide graft stability, and this is why nowadays I will use the pens from botiss to stabilize my graft. Really straightforward, easy to use, and it will change your results. You're going to get really good results just by using pens to stabilize the graft. Make sure the wound closes without tension, and I tend to try to close make sure it's like 110 closure. So even if you get any sort of pull during the healing process, you're not going to give any wound dehiscence. And aim for 2 to 4 millimeter labial bone thickness for long-term bone stability. Right. In 1 or 2 wall defects, you could go for autogenous blocks from the chin, from the hip, from the ascending ramus, or you could use the blocks from botiss. But we all know it has to be stage block grafting. I like to use my maxgraft blocks. Personally, you could either go for all cancellous or corticocancellous. Or sometimes with botiss bone rings, it can allow you to do simultaneous implant placement with bone block grafting. I just want to share this case with you where we needed to do block grafting. We waited 6 months and implants were placed. And obviously, we all know, or we've all heard about the bone ring technique. But anyway, stage block grafting is going to be another story for another time. And I really hope you enjoyed this short presentation about guided bone regeneration in the aesthetic region. And I'd like to thank botiss and botiss Academy for this kind invitation. I'm more than happy to take your questions and any inquiries. You could email me at our education@bird.uk.com. Please check our website to follow the courses we run. And you could also check my personal website for those in the United Kingdom who would like to take my clinical advice on their cases or accept their referrals. Thank you so much, and I really enjoyed being with you today. Wonderful. Now, I think we're going to go to see if you have any questions. Let's see. I know we've exceeded the time. Let's see. I know we. Right. Okay. David, can collagen be exposed? I think what you mean, the Jason membrane can be exposed. Ideally, to get really good results, you need to get, in my hands, you need to get good closure. Now, the good thing about resorbable membranes, if they're exposed slightly and you've got really good oral hygiene, you're going to get good results. Obviously, when it comes to non-resorbable membrane, this is when you really need to make sure that you don't get any wound dehiscence or exposure. Now, the mucoderm, this is the beauty about mucoderm. Mucoderm, providing the mucoderm is well stabilized, pins, sutures, and it's tucked labially and lingually, you can leave it exposed and you get really good healing with secondary intention. It works in my hands. Thank you very much, David, for the question. Okay. Yes, Michael. Michael, this is what I've showed you. This is something I've been doing recently and with good results. Mucoderm, I use it as a membrane and it works in my hands and it works 2-in-1. Yes, it's a bit more expensive than the Jason membrane, but the beauty of that you get 2-in-1. You get soft tissue grafting and you get a nice membrane and also you get good results. Obviously, you need to make sure that you're going to get really good blood supply coming from the bone. Salam, thank you. You've enjoyed the lecture. You made, okay, thank you so much. Thank you, Salam, and I appreciate your kind comment. Thank you so much. Anas, why you use mucoderm in those cases? As I've just said, Anas, mucoderm, I use it to bulk my soft tissue. I find it very useful, and I like to use, sometimes you have to do soft tissue grafting at the time of the extraction. It makes your life much easier when you come to place your dental implant. And also, I like to use the mucoderm to sometimes as a membrane, so 2-in-1. Shamir, thanks for the lecture. It's a great pleasure. Thank you. I hope you enjoyed it, and it's great to have you. Very good. Excellent. Any more questions? Michael again. What material do you use to make an impression? Oh, this is a good question. Obviously, it's a completely different topic, but I like to do flowable composite. Just dry your impression post, dry inside and flowable composite. You could either do direct customization or indirect customization. I'll be more than happy to discuss this in the future. Georgie, can you use cerabone over implant threads? Yes, you can. You can. I'm not saying you can't, but I'd rather, to get the best biological integration, Georgie, you should use something which will remodel into healthy bone. There are some reports, there's not strong evidence, it's not random controlled trials, but there are some reports showing higher rate of peri-implantitis when the implant is surrounded with xenograft compared to implants surrounded with healthy bone or like bone which can remodel into healthy bone. That's why personally I prefer to cover exposed threads with allograft and then use the xenograft to do the nice emergence profile. Thank you for the question. Saeed, thank you. It's great to have you, Saeed, from UK. Thank you very much. David again, in the aesthetic zone, do you tend to immediate or delayed implant protocol? I prefer in the aesthetic zone, and this is according to Cochrane systematic reviews and based on random control trials, to go for early placement. You get the safest and the best, most predictable results. Early, which is like 8 weeks after extraction in the anterior region. Immediate loading, yes, you could do immediate loading if you want to, providing you do very good soft tissue management. Irani, some techniques or tips for drilling blocks of xenograft material. Okay, the blocks I use are not Xenograft Irani, they're allograft, and they give you much better results than Xenograft blocks. But the advice here, they're completely different to the autogenous blocks. You need to make sure the block stays dry. This is really important. Because if you do irrigation as you're drilling, it's going to crumble. You need to make sure you use a very thin drill. I would personally go for 1 millimeter drill, very thin screws, and you need to also make sure that the recipient site is good. I personally like the corticocancellous, and actually I soak it. But this is only for the corticocancellous blocks, because when you soak it, the cancellous bone is going to be soft. So then as you screw the block into the recipient bed, the cancellous bone is soft, so it's going to remodel itself according to the recipient bed. So then you get intimate contact. Some people like to use all cancellous blocks because obviously that corticocancellous block, that cortical plate is going to stay there, most likely will not remodel. But in my hands, personally, I prefer corticocancellous, and it gives me good results. Right. Thank you very much. I think, what do you think? Okay, what do you think of angulated abutments instead of... I don't like that. Angulated abutments, they're gonna not solve the problem because you still get the recession 6 months afterwards. Angulated abutments, you're okay up to 10 degrees. The problem starts when you go like 20 degrees, buccolingual angulation. That's when you're still not gonna solve you're gonna solve the mechanical part, but not the biological part. The last question we're gonna take from Ahmed. Do you prefer doing immediate implant with flapless, GPR, tunnel, soft tissue grafting? Ahmed, I like to ask for one miracle at a time. And immediate placement, I used to do loads of immediate placement. I followed Joseph Kahn when he did immediate placement, but I still remember Joseph Kahn coming to London and showing 10 years post-op of the cases which he placed when he was doing loads of immediates, and disasters. So I try to avoid immediate as much as possible. But if I do, I like to raise a flap, I like to graft inside, I like to graft outside, and I like to do soft tissue graft. It has to be the full cocktail because the problem you cannot predict. And I think in my private practice, aesthetic results are really important. So we have to play it safe. David, it's great to have you. What time is it in Canada? So it's great to see you following this webinar all the way from Canada. Thank you so much. Okay, again, thank you very much, botiss. Thank you very much, botiss Academy. And it's great having you with us. All the best, guys.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.